On Health Her Way, we're asking the questions you want answered about your body.
Together with our female healthcare experts, we're diving into the questions that might seem too scary, too silly, trivial, or taboo. No topic is off limits.
Join us as we talk about Health Her Way.
Welcome back to Health Her Way. I'm Meredith Cunningham.
And I'm Brooklyn Albert. Today we're joined by Dr. Jennifer Phy. Dr. Phy is board certified in Obstetrics and Gynecology and subspecialty board certified in Reproductive Endocrinology and Infertility. She's practiced in Lubbock for over 20 years, and we are lucky to have her at Covenant Health.
If her introduction sounds familiar, it is because it is.
Because she's back.
She's back. We had such a wonderful conversation about PCOS. We wanted to dive deep into that. So now we are going to finish that conversation with another topic that we hear a lot about in media and a lot of women are affected by, and that is endometriosis. So let's dive right in with the basics. What is endometriosis?
All right. Endometriosis is a very common gynecology problem where the cells that are normally inside the uterus, that's called the endometrium, the tissue that builds up and prepares for menstruation. When those cells float out through the fallopian tubes, they can stick in the pelvis where they're not supposed to be. So they attach and look very much like little blood blisters. You usually can't feel them on a physical exam. You usually can't see them even with a very fancy ultrasound because they're usually very small. But they're menstrual cells, uterine lining cells that have attached outside the uterus where they're not supposed to be.
So they've gone exploring.
Yes.
Got a little lost and stuck around on an island somewhere that they're not supposed to be at.
Yes. And the body does not like that.
Okay.
So the body recognizes that those little cells have attached where they're not supposed to be. The cells can become inflamed. They can actually menstruate just like the uterine lining. And so they swell and can have bleeding at the same time of a woman's menstrual cycle. And the body reacts with a lot of pain, a lot of cramping. It can cause a lot of bloating. And so the body recognizes those little dots aren't supposed to be there. They're not harmful like a cancer, but the body is trying to defend itself. And so in the pelvic fluid of women who have endometriosis, there are a lot more chemicals, like they're called cytokines. It's a little bit like an acid in the body. And then also macrophages. Those are like the Pac-Man cells in our bodies that come around and eat things. And so the body is trying to defend itself, and it just creates chaos in there. And endometriosis can be extraordinarily painful. Even just very small lesions can be debilitating for women.
Wow.
So you said it's hard to see on an ultrasound. So what are some symptoms and how can this be diagnosed?
The common symptoms that we ask for our new patients on our questionnaire are, when is your menstrual cycle most painful? With endometriosis, it's typically most painful the day before and the first day of the menstrual cycle. Like patients will say, oh, the day before and first day is so miserable. And then as the flow kind of tapers off, they feel a lot better. They can often need over-the-counter pain relievers like Tylenol, ibuprofen, Midol, Pamprin, naproxen. I hear these names a lot, for patients who are suffering during their menstrual cycle. They may have discomfort with intercourse. That's not normal. So if someone's having pain with intercourse, that's a big buzzword to us. And then if they have to limit their activities, missing work, missing school, to me, that's a little extreme. I don't know anybody who enjoys their period or looks forward to it, but it shouldn't be debilitating like that. And then finally, one of the questions that I think is really helpful, do you apply heat? Like, do you use a heating pad or take a hot bath or use one of those little thermal patches? Personally, in the patients that I see, I haven't had anyone who was going to that length to use heat when they had their menstrual cycle who didn't ultimately have endometriosis when we checked for that. So I just think that's really a key. And so I think commonly when women are talking to their healthcare providers, maybe their primary care or gynecologist, I know people don't want to sound like they're complaining and things, but these are very important symptoms to mention, because this is kind of above the norm of, oh, it's my period, I need an Advil. These, other more extreme symptoms really deserve attention.
I'm sitting here thinking a lot now. I was like, oh man, I use a lot of Tylenol, and my hat is my favorite thing I've ever had.
Yeah.
God bless my IUD though, so no worries, no problems. Okay, so you said we can't see it visually, and with our eyes during an exam, and we cannot see it with an ultrasound. So ultimately, do you guys just have to guess and check on what it is to finally diagnose it?
Well, it really is a surgical diagnosis, and that makes it so hard because you really have to visit with the patient and decide, we're suspecting this. A laparoscopy, which is a minimally invasive gynecologic surgery, that is the tool we use to check for it. And so surgery is a big deal. Mm-hmm. We don't take that lightly. And so typically we'll say, we're very suspicious for endometriosis. And depending upon the patient's desires, like if the patient says, I just want to feel better, like my periods are horrible, well, medications can be very helpful. And I'd say first line treatment would be birth control pills. Birth control pills are going to minimize the menstrual flow. You can even give birth control pills every day where you skip the periods. And that provides great relief for many, many women from endometriosis pain. I'll have a lot of patients ask, if we skip the reminder pills at the end of the pill pack, is that bad if I'm skipping a period? And it is not bad, because when you're on birth control pills, it's preventing ovulation. You're not creating this thick, fluffy lining in the uterus. It's keeping everything suppressed. So there's no medical need to have a period if you're on continuous birth control pills. And so many women find great relief with birth control. There's other medications, injections, other medications that can be given that are more powerful to keep endometriosis away. But most of the time, you try birth control pills. And if patients say, wow, I feel so much better, then, you manage it medically. But in a lot of our patients, they're desiring pregnancy. So being on continuous birth control pills is not going to be okay. Mm-hmm. So we discuss the risks and the benefits of checking for endometriosis. And this can be done with laparoscopy. And if the endometriosis is seen at the time of the surgery, it can be treated immediately. And so that gives such great information and a treatment at the same time.
That's awesome.
So when you say that treated surgically, do you just kind of go in and clear out all those little explorers who have left their post?
Yes. And depending on how large the lesion is, where it is, if it's causing scar tissue, we have a variety of different tools that we can use, little heat-tipped instruments, lasers. You can excise, actually kind of cut out the lesion of endometriosis. So we have a lot of very effective tools that can be used to treat the endometriosis, same day, same procedure.
Wow. What's the downtime for something like that? Obviously, surgery all needs to be considered thoughtfully, and you need to take it easy afterwards. But you said earlier, minimally invasive. So, it's not like you're going to be down and out for weeks or months or anything, right?
Correct. So typically, and every surgeon will be different, but typically the surgery is done through 3 very small incisions, one in the belly button that is less than half an inch, and then a smaller incision to the right and left bikini areas that would be less than 1/4 of an inch. These are little tiny incisions that allow the camera to enter the belly button area and then the other instrument sites allow us to do all the work. And so typically patients go home the same day, and I'll encourage patients to take about a week off. That's going to vary depending on what you found and what you did. But most patients are going to be back up to their fairly normal activities within a week.
Wow.
Can you tell us a little bit about what can cause this condition?
Yes, it is a great question, and we still don't know exactly. I mean, there are genetic tendencies, so just with most medical conditions, they tend to run in families. The menstrual cells, kind of coming back through the fallopian tubes is the biggest theory of how women get endometriosis. But that happens in most women. Like 90% of women on their period, you'll find blood in their pelvis. That's not unusual. But for the dots of uterine tissue to stick, we don't know why that happens. And so there are some theories that maybe the uterine lining itself has this ability to attach and grow and create hormones and sustain itself. Another theory is that the lining of the pelvis, which should be like Teflon, isn't always perfect and isn't like Teflon, so it can stick. But we don't know. We don't know why some women get endometriosis and others not. There are some very rare cases where endometriosis can be in very unusual places, like the lungs, the brain. These are very rare, but I saw those in my medical training. And so in those cases, we think it's more from lymphatic spread, or actually from embryologic origins, like when we're forming as a baby, where you could have those uterine cells be in a completely bizarre place. So it's a really tricky condition, and we don't have all the answers, and people are actively working research-wise to try to have imaging or blood tests or things to predict endometriosis, but it's currently a surgical diagnosis.
I'm sensing a pattern here with some of the things that you say. Is we just don't know yet. Yet with PCOS, you told us in our last episode, it was kind of first discovered in the 1930s. So we're almost 100 years into it. As someone who's trained a lot and has a lot of education in these realms, is it frustrating sometimes that we still don't have answers to things?
Yes, very frustrating. And I feel the frustration in the patients that, might have been struggling with pain for a very long time, maybe since adolescence, since they first started their periods, or they've struggled to get pregnant for many years. And when we discover that endometriosis may be playing a role there, because the hostility, those cytokines and macrophages, they can create a hostile environment in the pelvis. So everything else can look perfect. You can have healthy sperm, open fallopian tubes, lots of pretty eggs, a healthy uterus, and just on paper, everything is perfect. And why aren't we pregnant? And then maybe you discover that it was endometriosis all along. So that can be very frustrating to patients. And so I just ask that patients ask their primary care or their gynecologic provider, a little bit more about this and voice those concerns. It's okay. This isn't complaining. This is reporting what your periods are like, so that they, might help you to be checked for endometriosis or have this discussion sooner than later.
So you said it's a surgical diagnosis, and we know that it can lead to problems with fertility down the line. But for someone who decides maybe not to have that surgery to find out, are there any other long-term concerns for not addressing it?
Yes. Endometriosis in the more severe stages can cause a lot of scarring in the pelvis or intestinal scarring. So if left unrecognized, it actually can cause some other health problems. It is a neurovascular disease, so it can cause excruciating pain and be debilitating in other ways, just from the pain it can cause. So I would say, aside from fertility, even if someone isn't pursuing pregnancy, it would be good for them to know that this is the source of their pain and to have it treated in some way. Some women do not want to have surgery. In those cases, we rely on medications. There is a medication called Lupron. This is a medication that kind of quiets all of the signaling to the ovaries, and that can help medically destroy the endometriosis. There's a lot of myths about this medication, that it puts you in menopause, and what if you don't come out of menopause? And that's simply not the way the medication works. If anything, it's making you prepubertal. That if I drew your blood, you'd look like an 8-year-old, not an 80-year-old. But when you take estrogen away and this medication suppresses all the estrogen, it mimics the symptoms of menopause, like feeling hot and grouchy and headaches and sleeplessness, but it's temporary. It's just as that estrogen level is falling, and that medication can be very powerful for patients that do not want to have surgery or aren't good surgical candidates. That can provide a lot of relief too.
With surgical intervention or, Lupron or birth control pills, if you get it under control, or especially with the surgical intervention, you take away those lesions, can they come back again?
They almost always come back if you don't treat them. Okay. So in women who are having this surgery for pain relief, then we usually hop right back on another medication to suppress their periods and try to see, how long can we go without those pain symptoms returning? And usually continuous birth control pills work very well, or Lupron, Depo-Provera. There's a variety of different medications that can be given to keep those periods away. And I would say on average, and the literature would support this, that patients will have years of pain relief if they have it surgically treated and then stay on something to keep it away. Now, in our patients who are desiring pregnancy, when we do the surgery, we can report a good fertility benefit for a year. So usually over that next 12 months, it would be unlikely for the endometriosis to return to the point it hurts the fertility. Not impossible, but we usually have this year window in which fertility is much improved by having the surgery, and we try real hard before it comes back.
So we talked about diet and exercise with PCOS. Can we talk about that a little bit with endometriosis and managing pain?
Yes. And so I think that there are some benefits to nutritional changes for women with endometriosis. So endometriosis, it is inflammation. The body is experiencing inflammation and kind of attacking the little dots of this endometrial or uterine tissue that has implanted outside the uterus. And so there are definitely foods that are more inflammatory than others. And I don't know that there is a perfect diet for this. And I would never want someone to think that they have to eat so perfectly or exercise so perfectly that their pain goes away. But many, many patients will find that when they avoid, processed sugars, ultra-processed foods, a lot of grains, dairy products, they'll notice that their pain with their cycles goes down a lot.
Wow.
And so I think one has to kind of experiment with their own diet and to see, if they introduce more healthy fruits and vegetables and nuts and seeds and lean meats, maybe shy away a little bit more from the sugars and grains and dairy. It's worth trying. And a lot of patients experience much less pain when they follow an anti-inflammatory type diet.
What about caffeine?
Yes. Well, I love caffeine.
Don't we all? You're sitting in the right
yes.
room. Yeah.
So I don't believe that caffeine negatively influences endometriosis. And, in general, caffeine in moderation can have some perks, revs up your metabolism a little bit and kind of gives people a little more mental alertness. So I don't really, eliminate caffeine for patients with endometriosis or PCOS. We're a little more cautious in pregnancy and say limit it to 2 normal size caffeinated, not maybe Texas size caffeinated servings, but even in pregnancy, 2 servings of caffeine a day is okay.
Yes. God bless you. Dr.
Yeah.
Doing the Lord's work, telling us we can keep our coffee in the morning. So we're about out of time. Is there anything with endometriosis that you really want us to reiterate or focus on before we go?
Yes, I would just encourage women to not accept feeling so miserable on their periods. It is okay to not look forward to your period. It's normal to need an Advil or a Tylenol. But if it's keeping you home from your activities, causing pain with intercourse, it being excruciating pain the cycle day before or the first day of the period where you just can't get relief, this is not okay. This isn't normal. It's above and beyond what we would expect as gynecologists. Many women with these symptoms will often ask a family member, and is this normal? And their family member might say yes, but then their family member probably has endometriosis as well. So just not accept that to be okay. That is not any way to live. And we have medications, small surgical procedures, many things that could improve the quality of life on their terms, nothing radical. If they don't want to have surgery or don't want to have medications, maybe we find a nutritional or other treatment, but to just don't be afraid to mention this to your care provider. So I would just ask myself, when are the periods the most painful? If it's the day before and first day, that's a little clue. Is it round the clock ibuprofen, Tylenol, those sorts of medications? That's a little unusual. Heating pad, pain with intercourse, missing activities. This is worth talking to your provider about.
Wow. Okay. Very enlightening. Thank you.
Thank you.
Before you go, we have a bowl of trending topics we want you to dig into and
Okay.
see what we're going to talk about today.
All right. My trendy topic says, controlling managing PCOS by focusing on weight and getting that under control with GLPs, diet, and exercise. So most women with PCOS struggle with their weight. 80% are going to be overweight or obese, and it's not their fault. It's from a very unfair metabolism. So improving our health and striving for a more normal body mass index is good. And this, even a small improvement can make a big difference. And many studies will show even a 10% reduction in the weight can spark ovulation and improve fertility. So we don't have to do something extreme. Now, diet, there's lots of diets trending out there, but I think our research done here in Lubbock has really proven to offer something research proven that can really help not only with weight, but improving fertility. Exercise, I believe in low impact, extended like 30 to 40 minutes most days of the week is most effective. And the GLP-1s, so these are all of your injections, super trendy, very, very popular. They're not really approved to take when you're trying to conceive. And I know that we hear a lot about Ozempic babies and women spontaneously conceiving on the medications, and it is good that their weight and health improve and to conceive, but there are warnings on these medications. They're not deemed safe to take when you're trying to conceive, and most fertility specialists will recommend being off the GLP-1s, the weight loss shots, for 2 months before you have unprotected intercourse or try to conceive because of worries about birth defects.
Interesting.
Yeah.
Okay. Wow. Good information. Thank you, Dr. Phy, for coming and
Thank you.
Yes, thank you.
explaining all of this to us and to our audience.
I
Very
loved it.
insightful.
Yes. No, it's been really helpful for both of us too. So thank you for being here. And if you guys have more questions or comments, find us on our Covenant Health Instagram page, and we will see you guys next time.
This podcast explores health-related topics with experts in their specialty for entertainment purposes only.
The information shared and discussed should not be considered as medical advice under any circumstance and is not intended to replace professional medical advice.
The views expressed do not reflect the views of Covenant Health System. For questions related to your personal health, always contact your physician.